Assalamu alaikum. I am Professor Dr. Jahan Ara. I am Professor of Obstetrics and Gynecology, Dow International Medical College and Dow University of Health Sciences. And I'm also the chairperson of Faculty of Obstetrics and Gynecology of Dow University of Health Sciences. Today, I've been taking a clinical session on antenatal care. Antenatal care being a very important aspect of obstetrics, and the whole obstetrics revolve around a good antenatal care. The basic aim, why is antenatal care so important? Because the aim of antenatal care is to have a healthy baby in the hands of a healthy mother. That is, at the end of the pregnancy, what you desire is a very healthy mother with a very healthy baby. And this is the best outcome which can be achieved at the end of a pregnancy. So, what is the WHO definition of antenatal care? The care provided by the skilled healthcare professionals to pregnant women and adolescent girls in order to ensure the best condition for both baby and mother during pregnancy. Here we label it as the healthcare professionals, because at places the obstetric care is provided by the midwives, the lady health workers, and junior doctors, and then by consultants like obstetricians, consultant obstetricians. So all of them are included in the category of skilled healthcare professionals. Whether a midwife or a lady health visitor, whatever she is, she should be skilled enough to deliver the antenatal care. Now, what are the aims of antenatal care? What are the objectives basically? Why is antenatal care is important? The basic aim is to screen or to segregate those women which are at risk of developing certain medical disorders during pregnancy, or which are at risk of having some harm during pregnancy. That is, to screen these high-risk women who are at risk of developing preeclampsia or fetal growth restriction or gestational diabetes or any other medical disorder, like who may have had certain form of thyroid disorders, or who may have neurological disorders like an epilepsy. Next is to prevent and to detect and treat at the earliest any complications which might be associated with the pregnancy. Then to educate the patient, to educate the mother, the new mother, about the physiology of pregnancy and labor. How is the pregnancy going to continue? What are the 3 trimesters of pregnancy? What are the common ailments of pregnancy? What she is expecting during pregnancy? When are the fetal movements going to start? And how is going to be her delivery? That is, how is going to be the start of labor? And this should be done by proper demonstration charts and diagrams, so that the fear of pregnancy and especially the fear of labor is removed and the psychology of the patient is improved. So the patient should be happy during pregnancy, so that she should have a very good experience during the pregnancy and labor. And at the end of the pregnancy, she should have a very healthy baby and a very good experience that she has gone through pregnancy. Actually, pregnancy is not a pathology. Pregnancy is just an altered physiology. So a pregnant patient, when goes through this antenatal period, should have certain help which is provided during the antenatal care period. Next, to discuss the couple about the place, time, and mode of delivery, provisionally, and care of the newborn. So they should have some idea in mind where they are going to have themselves booked, where they are going to deliver, like in remote areas, in villages and in the suburbs of the city, where there are not big hospitals and the hospitals are not present, then the patient may be asked to deliver at home even. But at that place, a skilled birth attendant, like a traditional birth attendant or a midwife or a lady health visitor, should be taking care of the patient. So they should know about the place and time and mode of delivery. And if they are in one of the high-risk group, then these patients should be asked right from the beginning to go and get themselves booked at a hospital where all facilities of high-risk pregnancy is available. Next, the other aim is to advise the mother about breastfeeding, the postnatal care, and immunization. There are certain immunization procedures which are required. Now, what are the objectives? The objective is again to ensure a normal pregnancy with the delivery of the healthy baby in a healthy mother. Next, coming over to how is the antenatal visits going to happen? That the patient comes to the antenatal clinic, she gets herself booked, then how it's going to happen and how it's going to continue. The first visit should be made as early as the pregnancy is possible. That is, as soon as she misses the period, she should go to the doctor, or she should go to the health facility where she wants to get herself to be booked, or where she wants herself to be frequently examined and checked. So the first visit should be as early as possible. That is, as soon as she misses the period, she should go to the healthcare provider and inform that, see, I have missed my periods, get myself tested for the presence of a pregnancy by a urine pregnancy test or a blood pregnancy test, which is also there as the serum beta HCG test, and then get herself booked at a health facility. Then, how are the return visits? First, at the first visit, then how frequently should be called on? After the first visit, she should be called every month till she's 28 weeks pregnant. Say, for example, if the woman goes to the doctor at 8 weeks of pregnancy, then the next visit should be on a monthly basis. That is, the next visit should be at 12 weeks. And after 12 weeks, the next visit again after 1 month at 16 weeks. And again, after 16 weeks at 20, and then at 24, and then at 28 weeks. After 28 weeks, she will be called every 2 weekly, every fortnightly. That is, after every 2 weeks till she's 36 weeks pregnant. And then once she's 36 weeks pregnant, she'll be called every weekly till she develops labor, or she goes into labor, or she's getting past dates or anything, so that she can be recognized that, see, there's some complication which may be occurring and the labor is not getting in. What are the various organizations which say about the antenatal appointments? The NICE guidelines, which is the National Institute of Health and Care Excellence, and WHO, they recommend that with an uncomplicated pregnancy, 10 appointments are okay. But in a multiparous patient with an uncomplicated pregnancy, there should be 7 appointments at least. The WHO recommendation is a total of 8 antenatal visits, right from the booking visit till delivery. This is somehow a WHO model in which they say that the first trimester should be, this is the antenatal care model, and this is again at which the first visit should be in the first trimester, and then followed by subsequent visits in the second trimester. Then in the third trimester, there should be 1, 2, 3, 4, 5, at least 8 visits. Or in those areas in which the access to the health facility is not possible, then the visit can be just 4 visits. First in the first, second in the second trimester, and in the third trimester at 32 weeks, and then again between 36 and 38 weeks. The patient should return for delivery at 41 weeks if the birth is not given. That is the time of term period. Here I want to tell you what is term pregnancy. Term pregnancy, or the period term, is a time when the patient may go into labor anytime. That is, when the baby delivers during this period, it's a term pregnancy. It's a full term pregnancy. Before this time, any baby born is a preterm baby, and preterm baby have problems. So the delivery should be in the term period. That is between 37 to 41 weeks of pregnancy. The period of term is between 37 to 41 weeks of pregnancy. And if the birth is not given till 41 weeks of pregnancy, the patient will be labeled as having a past term pregnancy. And the causes of this past term pregnancy should be looked upon. That she has a contracted pelvis, that she has some other complication, is she has a cephalopelvic disproportion, or are the dates wrong or something wrong. So the cause of this past term pregnancy should be looked upon. And if from the early ultrasound and from the dates, it's confirmed that she is 41 right now and is crossing 41st week, then she should be either induced and delivered or subjected to a cesarean section operation as per the conditions require. So the time of term is between 37 to 41 weeks of pregnancy, and during this period, delivery should occur. Delivery prior to 37 is preterm, and delivery after 41 is past term pregnancy. Okay. Now, what does the antenatal care actually comprises of? First of all, registration of pregnancy. You register the patient as your patient so that you have a bonding, a close liaison between the healthcare provider and the patient, so that she can discuss all her issues with you, problems which she might face during pregnancy or which she might develop during pregnancy. She should be discussing with the healthcare provider. The healthcare provider should take a proper history. Over here, I'm taking the name of a healthcare provider because as I told you, the antenatal care can be given by a midwife, the antenatal care can be given by a lady health visitor, it can be given by a traditional birth attendant, or can be given by a doctor, or can be given by a big doctor which is named as a consultant doctor. So all of them are included in the category of healthcare providers because they are skilled birth attendants and they are skilled people who can impart antenatal care to a patient who is pregnant. The second step is the history taking. You have to take a complete history. When did the pregnancy started? Did she has any problems before the pregnancy, or she has any issues during the pregnancy, or are there any other problems which she may be facing during pregnancy? Is she on certain medications in the pregnancy which might need to be changed or altered, or which might be increased in amount, like certain antihypertensive medicines which may be stopped and the patient may be shifted to a new medication protocol? So all these should be looked into the history taken. In the antenatal examination, you have to go through the general examination. You must have, in the previous classes, Dr. Uzma Nusrat must have taught you about the general physical examination and the obstetrical examination. How is the general physical examination being done and an obstetrical examination being done? So in the antenatal visits, you have to go through a detailed general examination and an obstetrical examination. Then you have to go certain booking investigations, and you have to educate your patient and advise them accordingly. Then, what are you going to do on the first visit, history taking and examination? You have to check for the particulars of the patient, the chief complaints. Does she has any complaint other than amenorrhea? Like does she has flu, she has headache, or she has nausea, vomiting, or diarrhea, or any other complaints? And the duration, for how long is she having these complaints? A past history of medical and surgical history. Does she has any other medical disease like tuberculosis, asthma, jaundice, diabetes, hypertension, or any other disease? And any surgical history, did she ever underwent certain surgical procedure? Then a detailed obstetrical history is important. You have gone through, Dr. Sana must have taught you about the obstetric history and the menstrual history. So you have to take about the obstetric history and menstrual history and the contraceptive history. That is, what is the interpregnancy interval? When did she have her last delivery or last pregnancy? Then you have to go through the family history. Does she has family history of certain diseases like diabetes, hypertension, cardiac diseases, history of twins, or any other communicable diseases? Drug history, is she on certain medications or not? And history of immunization, is she vaccinated against hepatitis B? Is she vaccinated previously for tetanus? And does she has influenza or flu vaccinations or not? So you have to go through the immunization history. Then the socio-economic history. In which socio-economic strata does she belong to? Because you should be prescribing medications and investigations according to her range. If she cannot afford, and if you're giving her very fancy and high expensive medications, she cannot afford. You have to give her the simplest form of vitamins and supplements which she can afford and she can take, so that she doesn't become anemic and she doesn't fall ill. Then history of allergies again is very important. Is she allergic to certain drugs, or is she allergic to certain other conditions? And history of transfusion. Did she ever had any transfusion? This is the examination part. You have gone through the examination. Dr. Uzma have told you and taught you the obstetric examination very well. She has given you how to go for the symphysiofundal height, how to check for the presenting part, how to check for the fundus, and how to do the lateral grips and see the gestational age and the presentation and everything. Fine. In the general examination, weight is very important. These are the various grips: fundal, lateral, and pollex. Fine. Then, what are the booking investigations actually? And why are the booking investigations done? Booking investigation, that is the investigations which are done on the first antenatal visit. A full blood count. A full blood count is important to check for the hemoglobin concentration, platelet count, and mean cell volume. Midstream urine specimen, a urine detail report, is important to evaluate for presence of asymptomatic bacteriuria or urinary tract infections. Her blood group and antibody screening is very important. Her rhesus status, whether she is rhesus positive or rhesus negative, or does she carry any atypical antibodies. Therefore, this is important. Otherwise, if not screened, the patient may develop rhesus disease, the baby may develop rhesus disease and may die in utero because of the undiagnosed rhesus disease. Hemoglobinopathy screening. In those patients in which the blood tests reveal a low hemoglobin levels and the low hemoglobin levels are not improving in spite of iron supplementation, then in those patients, what is required is for hemoglobinopathy screening. The hemoglobinopathies commonly encountered in pregnancy are the thalassemias, the sickle cell anemias, and certain other hereditary anemias. Now, why is an ultrasound important? Again, it's important to see for the dating scan and first trimester scan. Accurate pregnancy dating with provision of risk assessment for fetal trisomy 21. Pregnancy dating is very important, and the fetal risk assessment for the fetal trisomy 21 is important in the first trimester scan. You check for the presence of nuchal thickness. Nuchal thickness is the thickness of the knuckle fat pad at the back of the neck, which if it's more than 3 millimeter indicates that the baby may have some form of chromosomal anomalies or some form of aneuploidy like trisomy 21. So a first trimester scan is very helpful in evaluating these trisomies. The first scan or the first ultrasound should preferably be done between 10 to 13 weeks of pregnancy. Why important? It determines the mean gestational age. It detects if there are twins or triplets or any other multiples of pregnancies present. And it will screen, like I told you, the estimation of nuchal thickness is going to help you for screening for Down syndrome. Ultrasound screening for fetal anomalies normally is done between 18 weeks and 21 weeks of pregnancy. If ultrasound scan at 20 weeks of pregnancy identifies a low-lying placenta, then an additional ultrasound is required at 32 weeks of pregnancy. So these are all clinical steps which are required. That is a dating scan and followed by anomaly scan between 18 to 21 weeks of pregnancy. Then, if the 20-week ultrasound shows a low-lying placenta, repeat scan at 32 because it may migrate up and may not remain a low-lying placenta or a placenta previa, which is dangerous and which may bleed during pregnancy. Next, the third ultrasound is required at third trimester to monitor fetal growth and well-being, and everything is going on fine before you let your patient go into normal labor. Right? Now, what are you going to do at each antenatal visit? On each antenatal visit, check the obstetrical record, which is important. Measure the blood pressure, check for urine proteinuria with the dipstick method. Ask the patient for any complaints and identification of problems. Gestational age should be calculated at each visit. That, for example, if she came at 26 weeks of pregnancy and she's again coming after 1 month of pregnancy, calculate with the last menstrual period and the expected date of delivery that she must be around 32 weeks of pregnancy right now. So calculate the gestational age. And when you are examining the patient, the symphysiofundal height should correspond to the calculated gestational age as per her last menstrual period or as per her the last first antenatal visit calculated LMP and EDT. Okay, so gestational age should be calculated at each visit. Listen, General examination again is important because you check for the presence of anemia. Is she developing jaundice, or is she developing fetal edema, or if the edema is becoming so severe that it's extending into the tibia towards the tibia, or it becomes pre-sacral. So you have to check for the presence of edema, jaundice, and anemia, and for any other symptoms like a raised JVP or anything like this. Symphysiofundal height measurement is important, and the patient must be inquired about the presence of fetal movements and fetal heart sounds. How much fetal movements are required every day? After 28 weeks of pregnancy, the patient usually feels 10 to 15 movements per day. And these movements are more at the end of the day, like after 6 p.m., when the patient feels more fetal movements. So the fetal movements are more at the end of the day, like after 6 p.m. onwards. And there should be around 10 to 12 fetal movements per day. Or the patient may be feeling fetal movements after every 2 hours. Then her health education is important. What she should be eating, what sort of diet she should be taking. Like she should have adequate quantity of carbohydrates, fruits, vegetables, fibers for fruit, vegetables, and for fibers. Then meat, egg, milk. She should take adequate quantities of carbohydrates, proteins, fats, and vitamins and mineral supplements. Prophylaxis and treatment of anemia is important. If you are thinking that on the first booking visit that she's anemic, then you have to give her iron supplements. And then at each antenatal visit, to develop a plan, develop an individual plan for every patient, because every patient is different. Even in low-risk patients, she may not deliver so well. So a delivery plan should be formulated. Now, what nutritional supplements are required? These are the basic nutritional supplements that should be given in antenatal period. Like she should be given folic acid. The recommendation is 400 micrograms per day. Why is folic acid important? It prevents congenital abnormalities. It prevents neural tube defects in the baby. Neural tube defects like anencephaly, spina bifida. Folic acid prevents neural tube defects. So folic acid supplements in a dose of 400 micrograms per day should be given. Next, iron supplementation is important. Oral iron should be given in a dose of 30 milligram elemental iron per day. Iron is important because it prevents maternal anemia, it prevents puerperal sepsis, it prevents a low birth weight baby, and it prevents prematurity. Calcium supplementation is important because it reduces the risk of preeclampsia, and for the developing baby, the presence of calcium and vitamin D is very important for the development of bony structure of the baby. So an oral iron of about 1.5 to 2 grams should be given to the patient in pregnancy. Vitamin D is very important, and 10 micrograms of vitamin D supplements is really required. And if there is vitamin D deficiency, replace vitamin D, because vitamin D deficiency is associated with a lot of fetal problems and a lot of perinatal problems. Then maternal assessment. Maternal assessment includes screening for high risk for developing preeclampsia. Anemia should be corrected, detected, and treated, and underlying blood disorders like thalassemia, sickle cell anemia should be sorted out and treated. Mother should be sorted out for the presence of asymptomatic bacteriuria. Intimate partner avoidance should be sorted out and should be helped. The mother should be helped about this. She should have a secure, safe, and psychologically stable pregnancy. If she's having tobacco, if she's on tobacco and alcohol abuse, she should be asked to reduce or to restrain from such products. HIV and syphilis and tuberculosis should be screened. And then we as Pakistanis are very high risk for developing gestational diabetes. So the woman should be screened for gestational diabetes. Now, what is fetal assessment? Number 1, ask the patient about the daily fetal movements. Counting to 10 to 15 times is normal. Like I told you, the fetal movements are more after 6 p.m. Measure the symphysiofundal height. If it doesn't correspond to the gestational age, the fetus is not growing properly. If you feel that the amniotic fluid volume is less, again, the fetus is not growing properly, go for a growth ultrasound. Go for an ultrasound and check why is the baby not growing properly. So a simple symphysial fundal height measurement is going to tell you the growth of the fetus. The next step after this is an ultrasound. In a normal pregnancy, a dating scan in first trimester, followed by an ultrasound, a normally ultrasound between 18 to 21 weeks, and a third scan at 32 weeks is quite enough. At times, you require another ultrasound just before the time of delivery to see that everything is normal and the patient can proceed till term for natural labor to start. At times, a cardiotocography is required. What is cardiotocography? Cardio means the fetal heart and toco means the uterine contractions. Cardiotocography is usually done during labor, which is when it's called intrapartum cardiotocography, but may be done in the antenatal period for assessment of fetal well-being. And that's called antepartum or antenatal cardiotocography, in which you want to see the heart rate response of the baby in response to a fetal movement. This is what is seen in antenatal period. And if the woman is contracting, if the uterus is contracting, you want to see the effect of uterine contractions on the fetal heart rate. If there's some suspicion that the patient is developing an intrauterine growth restriction or a small fertility fetus, then a Doppler ultrasound of fetal blood vessels, like an umbilical artery Doppler, is required. What preventive measures are required? You may require antibiotics for asymptomatic bacteriuria. The patient may require anti-D immunoglobulin prophylaxis if she is Rh negative and her husband is Rh positive. That is, she's carrying a Rh positive baby. Then she may require antenatal anti-D prophylaxis in order to prevent the rhesus disease of the newborn, in which the baby has jaundice because of Rh incompatibility. Next, preventive anti-helminthic treatment, because hookworm infestation and pinworm infestation is common in pregnancy, and this may lead to iron deficiency if this helminthic infection or this protozoal infection is not treated properly. A tetanus toxoid vaccination is required at 7th month and 8th month, or it may be given as early as after the first trimester in order to prevent neonatal tetanus. जिसको उर्दू में कहते हैं तशन्नुज की हिफाजत के लिए tetanus toxoid दिया जाता है. Then is the malaria prevention. Malaria prevention in those areas where malaria is very much prevalent. You have to give malaria prevention. Then pre-exposure prophylaxis for HIV prevention. If you have a suspicion that the patient may be predisposed to HIV or AIDS, then you need to provide pre-exposure prophylaxis. Now, the intervention of common physiological symptoms. The common physiological symptoms of pregnancy include nausea and vomiting. You can ask them to take soft ginger. You can take certain medications. Heartburn by simple lifestyle modification and certain antacids. Leg cramps can be prevented by giving calcium, magnesium supplements and non-pharmacological treatment like massage or with oil or something. A low backache and pelvic pain, like regular exercise, physiotherapy, supporting beds and acupuncture. Constipation may be prevented by giving a high fiber supplemental diet. And varicose veins can be prevented by compression stockings, leg elevation, and water immersion. So these minor ailments of pregnancy can be prevented by minor things. Not always my medicine. Now, what antenatal advice would you like to give to the patient? For antenatal advice, you have to advise about the diet, a nutritious, balanced, light, easily digestible diet, which is rich in protein. That is, you should ask them to take fruits, vegetables, egg, meat, and milk. The patient should be resting and sleeping properly. The bowel habits should be adequate, and she should not be constipated. Next, personal hygiene is important. Clothing, shoes, and belt. She should be using light clothing, and the shoes should be very comfortable because at times pedal edema develops and appears. She should not be using a tight belt which may compress the baby or the abdomen. Dental care again is very important. She should be screened for the presence of dental caries, because if the woman is having dental caries or there's a bad dental care, then she cannot eat properly. And if she cannot eat properly, there are problems that she may not be taking her diet properly and she may be having problems. Then breast care is important, and she should be advised about the coital frequency. Traveling again is important. She should not travel after 34 weeks of pregnancy, and if she's traveling, the chances of fall or preterm labor may not appear. Smoking and alcohol should be abandoned, and she should be advised not to smoke or take a lot of alcohol. Safe immunization, like safe vaccination of tetanus toxoid, hepatitis A virus, B virus, and rabies vaccination, if required, may be instituted to the patient. Drugs should be formulated. There are certain drugs which should be stopped as the pregnancy appears. And then the patient should be mentally prepared at the start for a healthy pregnancy. She should exercise properly. And a birth plan should be formulated. Where is she going to deliver? How is she going to deliver? And when is she going to deliver? She should be told about the warning signs. That is, when the water bag ruptures, she should be told that that's how the water is going to pass. She may have cramping pain with slight passage of mucus, which is called show, and that's a onset of labor. She should be instructed about the child care. How is she going to take care of the child? How is she going to breastfeed? How is she going to take care of her health? Who's going to keep her child if she is a working woman? All these problems need to be sorted out in the antenatal period. These are the certain warning signs of pregnancy: cramping contractions, persistent vomiting, frequency or less urine, oliguria, rupture of membranes with passage of gush of fluid per vagina, absence of fetal movements. She's not feeling any movements. That's very dangerous. Muscle irritability, spotting or vaginal bleeding anytime in pregnancy is dangerous, and she should immediately report to the doctor. So these are the actual warning signs, and for these warning signs, she should immediately consult the doctor. So this is the end of the antenatal care, and now I want you to ask me questions on chat if you have any problems or questions. And then again, I would like you to please pick up your obstetrics for 10 teachers books and read up the antenatal care for those who haven't read it right now. Now, I am taking the questions on chat. Which framework do we follow? The best framework to follow is monthly up till 28 weeks. And after that, every fortnightly till 36 weeks, and then weekly after 36 weeks. All supplements needed. See, usually the diet is not adequate, but if the patient is not anemic at the start of pregnancy and she has good iron stores, then usually supplements are not required. But considering our setup, supplements are usually needed. I have repeated about the visits. Cardiotocography. Cardiotocography is a graphical trace of fetal heart rate and uterine contractions. You are in the beginning of third year. When you will be coming to the wards and will be doing your actual physical postings, we will show you the cardiotocography machine and how a cardiotograph is taken. Besides, you will be taught about cardiotocography in later lectures when you are in fourth year also. So, any other questions? If you So basically, the antenatal care revolves around the whole of the pregnancy. And if you provide good care to the patient, during the antenatal care, the patient usually doesn't have any problems whatsoever in the antenatal period. And the basic aim is having a good live baby. Then there's another one thing which is very important about the antenatal care is identification of the high-risk pregnancy. Like you have to segregate the group of patients into a low-risk group and a high-risk group. Low-risk group which have less likely chances of developing complications in pregnancy, and then there's a high-risk group which have high chances of developing complications in pregnancy and who may require more expert care and advice. So for the low-risk group, they can be managed by the midwives in your hospital facility and by the junior doctors. But as soon as they develop any complication or you identify that this patient may develop certain problem or complication in pregnancy, she should be referred to a consultant where a proper care or the proper care should be given. Like patients with medical disorders, like patients who enter pregnancy with hypertension or who are very much obese and have chances that they may develop gestational diabetes in pregnancy. So these patients should be categorized into a high-risk group and should be segregated over there. So any other question? If you have any other questions, you can put it on the chat. And for the next like half an hour or so, I would like you to please open up your books and read through it. Read the antenatal care. I think you people know about the books which are recommended for obstetrics and gynecology. Please buy 10 teachers for obstetrics and 10 teachers of gynecology. And both these books are very basic. And as you are going through your lectures and as you are taking your clinical classes, you have to go through these cases. Because right now we cannot show you or ask you to interact with the patients directly. So we would like you to at least go through the theory. So when physical postings start, you can have the know-how and all the background theoretical knowledge of everything, so that you can imply or you can then put it onto the patient. And when you see all these things, then and if you have gone through the cognitive part of your teaching, then you can be very good in your practical clinical postings. So please read through this topic. So any other questions, you can ask me on the chat if you have any other question. So I think with this, I should end my presentation.